I'm going to welcome everybody to this is actually the first Minnesota PVA webinar. And so I appreciate you joining. A few housekeeping things. We are recording this, and we are going to put it on the web for people to view afterwards. To ensure minimal distractions, we have cameras and microphones turned off right now. And then we'll also be taking questions. So if you have a question and you don't want to type it in the Q&A, because sometimes that's a little cumbersome, just use the hand raise and we'll turn the microphone on, and then you could just ask your question. So so with that, I'm going to welcome Deborah Klosik and Ryan. Okay, let me get it right. Gebauer, did I say that right, Ryan?
Yes, you did. You did.
Perfect. They're from Quest Healthcare, and I really appreciate you guys being with us today. So I'm going to turn it over to you, Deb, to tell us a little about you.
Yeah, thank you, Vicki.
Deborah, do you want? Deborah, I have mine pulled up. Do you want to run off of your notes, and then I'll share my full screen?
Do you want to do that? That would work great because I'm not seeing. Yeah. Okay, so how can you just easily switch that? If we can't easily switch it, I can do it this way, Ryan. What do you guys see when I flip to the second screen? Are you seeing a screen with notes or just a screen with the presentation slide?
Just a screen with no notes. Okay. It looks good.
Okay, perfect. Well, then I think it will work because I'm not seeing the normal view, but I think I was able to pull up a different pane. So if that's fine, Ryan, why don't we proceed? That way we don't have to delay things, and I think everybody will be able to follow along. Okay. So my name is Deborah Klosik.
I'm sharing.
Ryan, I think everybody's seeing my screen right now. Hello?
Oh, yeah, because I have it. I'm sharing right now.
You are sharing? So,
yeah.
Okay.
It says PVA, MS, and SCI. That's what I'm seeing.
Right, they see my screen. All right, go ahead, Deb.
Okay, perfect. So I will go ahead and get started. I apologize for the technical difficulties. This hasn't happened before, but we are great at troubleshooting, so we'll just proceed. Vicki was kind enough to invite Ryan and myself to present today, and the topic that we're going to cover is neurogenic bowel dysfunction in multiple sclerosis and spinal cord injury. So first, I'm the regional educator in Minnesota for Quest. I cover a 6-state region, and Ryan is my colleague. He is based in Florida. And Ryan, I'd love you just to give a brief introduction of who you are, kind of your background, your injury, and then we'll start moving through the presentation, and Ryan will share a lot of his personal experience as we get started.
Perfect. Yes, thank you. Ryan Gebauer here in Fort Lauderdale, South Florida area. I was injured 29 years ago at the age of 16 when I purposely climbed a tree with the intentions of leaping out of a tree into a canal. When I leaped out, I did a belly flop, and that's when I severed my spinal cord as a complete separation at the cervical 3-4 vertebrae. I've been a quad for 29 years now and part of Quest for almost 10 years.
Thank you, Ryan. And like I mentioned, Ryan will get a little bit more into his journey throughout the presentation. And feel free, if questions come up and you want to send them through the chat, or Vicki, if you want to unmute, or however you want to do it, we're happy to have it be an interactive presentation as well for those that are live with us today. So just to make sure that you're seeing the same screen that I'm speaking from, Ryan, I have neurogenic bowel pulled up, and
yes.
On the screen it's slide 2. Perfect. So just to kind of cover what neurogenic bowel is, it's the loss or absence of normal intestinal function due to nerve damage or birth defects. It's characterized by the inability to control the elimination of stool from the body. And, it's diagnosed in a multitude of ways. Typically, a physician does a history and a physical exam. They include rectal testing with the assessment of anal reflexes. Diagnostic testing can be anal rectal manometry, electromyometry of anus and rectal strength, and it can also include MRIs, CTs of the brain, of the spinal cord, or ultrasounds of all of these areas. Each of these patients are at high risk and will need an effective program to manage neurogenic bowel dysfunction. Spinal cord injury patients, 95 will experience NBD. Depending on the level of injury of the spinal cord above or below the T12, these patients will either have flaccid, which is lower motor neuron bowel, or reflex bowel, which is categorized as upper motor neuron bowel. And bowel issues are ranked as the #2 cause of AD or autonomic dysreflexia in spinal cord injury patients, and affects up to 95% of those patients. The other groups that are at risk for a neurogenic bowel dysfunction are stroke, MS, long-term care, and traumatic brain injury. So we're going to be focusing on MS and spinal cord injury today. So looking at MS, 1/3 experience constipation and 1/4 experience incontinence. And this is based on the extent of the lesion that impacts that bowel function or bowel symptoms for these MS patients. So the next slide I have is, the title of it is the PVA, and looking at your help and your members with multiple sclerosis and spinal cord injury. As you're all well aware, the PVA is known for their focus on serving veterans with multiple sclerosis and spinal cord injury. 1 in 4 of their members lives with MS, and the PVA is skilled at securing unique MS benefits for their veterans from the VA, and they're adept at navigating the VA to get their members quality care for their condition. More than 5 million Americans are living with paralysis, and 1 in 4 are a result of spinal cord injury or disease. You're probably very familiar with the Veterans Health Administration, and through that, the spinal cord injury and disease system within the Veterans Health Administration provides that interdisciplinary team approach to manage physical, psychological, environmental, and interpersonal support for individuals living with spinal cord injury. So let's look at MS in a little bit more detail. What is MS? MS is a chronic inflammatory disease of the central nervous system. It mistakenly attacks that protective layer around the nerves in the brain and spinal cord called the myelin. These damaged areas are known as plaques or lesions, and they vary with severity. MS is believed to be an autoimmune disorder. The immune system is derailed, generating immunity against itself. And then the antigen specificity of the immune response is unknown at this time. In particular, patients with MS, their strong indications or the loss of tolerance is directed towards that various attacking on that myelin proteins for these people suffering with MS. I'm going to flip to the next slide. Next, let's look at the psychosocial, physical, and the economic impact of bowel dysfunction. So for those patients that are suffering from MS and are affected, with the neurogenic bowel, it can have a substantial negative impact on quality of life, social integration, and personal independence. Patients with MS rank bowel problems as the 3rd most impactful thing for quality of life. It's considered one of the things that impedes their ability to interact and have social interactions, have personal independence, especially depending upon the amount of time they may be spending on their bowel management program. It's considered the primary cause of the inability to work for patients suffering with MS after spasticity and incoordination. Concurrent symptoms that complicate neurogenic bowel contributing to impaired quality of life are, the hemorrhoids that can be caused from, non-regular bowel movements or straining, abdominal pain, fecal impaction, rectal prolapse, anal fissures, and autonomic dysreflexia, to name a few. The cost for standard bowel care in patients suffering with neurogenic bowel related to fecal incontinence is just under $12,000 annually. So this next slide, it's just a survey for patients that have MS when, asking them, how it impacts how MS and their bowel routine, how does it impact their daily life? One response, constipation is the hardest aspect of MS. I have to get up at 6:30 in the morning to make my bowels work. I spend too much time in the bathroom or on the toilet. Fecal incontinence. It's hard to leave the house for fear of having an accident or having leakage. One of the worst parts is not knowing when I need to empty my bowels. I try to empty every day and I go to the toilet just in case. Sometimes I leak. And then both dealing with fecal incontinence and constipation. So getting cramps 24 hours before emptying, which can give a sense of urgency, and then straining that again could cause those hemorrhoids and pains and fissures. And then if they're having a high fiber diet to kind of help with the constipation, they can increase issues or episodes of fecal incontinence. So next, let's just look at bowel management and lifestyle. Again, this is a survey response, 155 MS patients, one third out of 155 MS patients, 1/3 of the patients said they spent more than 30 minutes daily on their bowel management routine. Patients basically were fitting their life around their bowel program. And the length of time for bowel management stops patients from working outside the home and impedes their daily activities. Again, interfering with social activities and relationships that these people are able to form because they don't have the confidence in being able to leave the home and the amount of time it takes for them to get through their program. So next, let's look at spinal cord injury, and neurogenic bowel disease. At this point, Ryan, it might be a good time for you to actually just kind of give a little bit more detail on your care once you suffered your injury and a little bit of the experiences that you've faced or challenges you faced at the beginning.
Absolutely. So upon injury, had hospitalization, surgery for the first 3 months, quite a few cervical fusions, 3 of them in total. And during that period of time, I ended up developing a bad stage 4 wound on my buttocks. I was on a ventilator. Also had to deal with UTI, staph infection, and all this prevented me from getting into rehab down in Miami. With that said, I was not on a proper bowel program. I was using an external condom, Texas catheter for the voiding of the bladder. I wasn't educated on autonomic dyslexia. So a lot of things were not in place. My first experience of autonomic dyslexia is I had sweating symptoms, but it was thought because I was overheating due to the fact asking for sheets and blankets. I'm just putting layer and layer of sheets and blankets on me to keep me warm. Wasn't the fact of sweating from overheating. It was the autonomic dyslexia pressure. So when I wasn't admitted to rehab, insurance and my mother got together and decided to transfer me to an inpatient acute rehab that would take me right away. And I was there for 3 months, OT, PT, speech, recreational therapy. But the importance was that I learned that SEI wasn't just the physical aspect of an injury, it was also the secondary, which is the bowel, bladder, skin integrity, and in my case, because I'm above that T6 level, autonomic dyslexia. And it was at that time I was put on a proper bowel and bladder program.
Thank you, Ryan. Thanks for sharing that. And then we'll get into a little bit more detail on Ryan's current program and how that evolved as we go a little bit further into the presentation. But so looking at this epidemiology of spinal cord injury, 18,000 new injuries occur each year, and of those cases, 78% are male. Roughly 42% of people with spinal cord injury are veterans, and it means that the injury is in the mean injury age has increased from 28.7 years in the 1970s to 42.9 years in the late 2000s. This trend reflects in large part the similar trend in the average age of the US population. One of the main causes of spinal cord injury is vehicular crashes, then falls, violence, primarily from gunshot wounds, is it causes 13% of all spinal cord injury. And then sports and recreation account for 8%. Medical and surgical incidences of causing spinal cord injury are as high as 4%. Reported prevalence rates vary for autonomic dysreflexia in the US, but the accepted rate of 48 to 90% of all individuals who are injured at the T6 or above have experienced an episode of AD at some point in their care. So patients who have complete injury, meaning no motor sensation below the level of the spinal cord lesion, have a much higher incidence of AD, though 91% with complete injury versus 7% of risk of AD with incomplete injury. So as Ryan mentioned, he's experienced episodes of autonomic dysreflexia, but what is autonomic dysreflexia? It's a potentially dangerous and in rare cases, lethal clinical syndrome that develops in individuals with spinal cord injury, resulting in acute uncontrolled hypertension. It affects those mostly with an injury above that T6 level, as Ryan has. And AD can be life-threatening if not treated promptly and correctly. It can lead to stroke, seizures, and even death. So it's really important that all caregivers, practitioners, therapists, anyone dealing with someone with spinal cord injury and interacting with these individuals are aware of the syndrome and recognize the symptoms and understand the causes and the treatments to managing AD. So, next, looking at some of those signs and symptoms, there may be no symptom despite high blood pressure. So most common symptoms, like Ryan mentioned, I think he said flushing and he got hot, but most common symptoms are the flushing of the skin above the level of injury or just a sudden onset headache. In patients with persons with T6 injuries or higher than the T6 area, the communication between the parasympathetic nervous system and the sympathetic nervous system is interrupted. So that stimulation of one branch no longer corresponds to the suppression of the other, resulting in negative feedback, and then the systems are no longer working together appropriately. So, it's really important to monitor the blood pressure for those that have an injury at or above that T6 level. And if that diastolic blood pressure goes up 20 milligrams of mercury or more, and that diastolic goes up 10 milligrams or millimeters of mercury or more, it's then the baseline for that individual person it is an area of concern. So it's really important for these persons with a T6 injury or above to really know what their baseline blood pressure is and to monitor that, so that you're aware of any sudden changes, because as I mentioned earlier, there may not be any symptoms, but all of a sudden a rise in blood pressure. The sudden rise in blood pressure with AD is usually associated with bradycardia. And, for these persons that are dealing with it, it's important that they know what their mean, baseline blood pressure is as well to help manage this and maybe prevent autonomic dysreflexia from happening. Ryan, at this point, do you want to share a couple instances that you've experienced and how they were managed?
Yep. So first one was that experience with the sheets and blankets. I, in the past, ingrown toenail, skin wounds on the buttocks, upper thigh, urinary tract infection. I typically get a pounding headache. And if I also any type of like pressure on a wound gives me a lot of sweating. This past Monday, I recently had a caregiver that, without my knowledge, threw out the old bedside bag, exchanged it with a new one, kept the cap on it. My evening caregiver didn't realize it, took the tube, connected it to my Foley, and an hour later I'm trying to void and I can't. Had no idea what was going on. Thankfully, I was able to get my neighbor to come over, and it took about an hour and a half with a pounding headache to realize that when the caregiver put the new bedside bag on, never took the cap off, and that's what was preventing me from voiding. So, although 29 years later, I do experience some of these events. So hopefully that will never happen again. But it is a pretty scary situation.
Oh, well, Ryan, I'm glad everything was okay, and thank you for sharing that. But it, as he mentioned, he's been managing this for 29 years, and weird situations like the one that happened on Monday can occur. He mentioned all the other situations that he's dealt with, but looking at what are some of the common causes of AD, I believe he mentioned each one of these. Full bladder, full bowel or painful bowel movement, a skin impairment, whether there be a pressure injury starting, or there's something else going on where genes are rubbing against the skin or pinching it. So all of these things are really important to be aware of. Even looking for insect bites, or like I mentioned, the constrictive clothing can be something that can trigger AD in these patients with that injury above the T6. So next, kind of moving on and looking at common causes of constipation. So obviously there's a long list of things that can cause constipation. Obviously high, in this group of people suffering from neurogenic bowel dysfunction, there's oftentimes many medications that are being taken. There can be associated endocrine or metabolic diseases. Neurological disorders, of course, can cause constipation. There's also that myopathic disorder, so that muscle weakness that's not allowing things to function normally. And then just general disability, of course, poor mobility, and then diet and fluid intake. All of these contribute to constipation. The most common medications that lead to constipation, as everyone's well aware of, are narcotics and opioids. These are two commonly prescribed medication categories for people to manage pain. However, they suppress bowel function and they lead to that opioid-induced constipation. And then dehydration is hugely contributing to constipation. It limits the water available in your intestines for absorption, which leads to that slowing of the intestine, and then constipation sets in. Once constipation sets in, it's, as we all know, it's difficult to kind of turn that around. So making sure staying as hydrated as possible and keeping on a diet that is working for yourself. Some people can't have a high fiber diet, but however the diet may help with their bowel function is really important. And then, there's also many other things that can contribute to constipation that are just regular things that are taken on a daily basis, that someone may need antihistamines during, allergy season. They may be on a diuretic for a period of time. So there's a long and lengthy list. Somebody may be affected by many or only one or two, but any could cause constipation. So looking at this like from a bowel management perspective, and how, to manage the daily routine without it having it overtake your life, and have no accidents and no constipation issues. Looking from the perspective of red flags, if there's accidents occurring, or, such as incontinence or leakage, obviously that the program isn't working. If it's painful or really difficult to pass, stool every time, obviously there's some constipation issues taking place. Something that's taking 30 minutes or longer, where you're having to really kind of plan your morning or your day around your bowel protocol. Excessive gas, is another thing. It's that extra stimulation. And then, looking at it from that perspective of how it affects someone's quality of life, excluding bladder dysfunction, gastrointestinal disorders are the most common complication, especially for those with patients with spinal cord injuries. So, it's really important, as Ryan mentioned, being on an effective bowel program. And, if you have one or any of these things kind of jumping out or occurring on a regular basis, it might be appropriate time to look at what's being done, and if there's anything that could be changed or added to the program to make it more effective. Ryan, do you want to just share a little bit at this time, kind of what your protocol is and maybe how it's changed over the years?
So when I was in acute rehab, I was introduced to a mini enema called Theravac, and that was done every other evening during shower night. Once I was discharged and reintegrated into community, I changed it to mornings because I wanted to have my afternoons and evenings and weekends to not have to rush home to do a bowel program. I continued to use that mini enema every other morning for 5 years until I found out it was no longer available, not because it was a harmful product or FDA issues. It was the acquiring pharmaceutical company was no longer going to manufacture that line of product. So put me in many individuals in a situation to find other agents to help with the bowel program. So we started using the large volume over-the-counter fleets enema, which took a lot longer. It also caused sweating symptoms. But during a long period of time, especially here in humid South Florida, it was causing more dehydration. So we started moving to suppository. Suppository took a lot longer than the fleet's large volume as well as the mini enema. But what it was doing that the other two weren't doing is that it was causing mucosal discharge or accidents, and sometimes even hours after the program or even following next morning while I'm laying on my side in bed. So this was becoming a hardship. I was in a college course, drinking a cup of coffee. I just did a suppository bowel program early in the morning, and I ended up having a bowel movement while I was in class. I was humiliated. Thankfully, I met a quadriplegic on campus earlier that semester, and I asked him what he was using, and he was on all types of narcotics and opiates and just things that were going to make him constipated. So I knew he would be the best resource. Plus, he was also involved with support groups, which I was not. And he introduced me to Enemies. And when I went onto their website, I chose Enemies Plus, and that's where my journey began of change and improving of quality of life for me and my bowel program.
Thank you, Ryan. Um, as Ryan mentioned, the bowel program has to work for the patient. It needs to, take into account attendant care time, personal life goals. Like Ryan mentioned, he was going to school. He didn't want to have to manage his entire day around that bowel program, as well as, didn't want to risk going out in public and having accidents. So all of those things need to be considered, and really looking at that self-rated quality of life for these individuals. As Ryan mentioned, he moved his bowel program to the morning, and that typically is what's recommended. Mass movements usually occur 1 to 3 times a day, usually after that first morning meal, and it's strongest for about 15 minutes after that meal. And so if someone's able to establish a morning protocol, that is what's recommended. And then of course, adding that stepwise approach to include, adequate fluids, adequate fiber, and then introducing Enemies mini enema, as Ryan does, to manage that, to have a safe and effective and efficient bowel movement regularly. This slide I just like to show, it's just improve, establish, initiate. So improve that stool consistency, establish a regular time for elimination every day, and then initiate the complete emptying of that rectosigmoid on a regular basis so that you're not dealing with anal incontinence, constipation, or fecal incontinence with overflow. Just to show this, the Enemies mini enema is recommended by the PVA guidelines. It's recommended over glycerin, mineral oil, and vegetable oil-based Bisacodyl suppositories. And this is just a study I always like to mention because Ryan had mentioned that he was switched to suppositories during his bowel care journey. This, on the left, Enemies was studied at the SCI model facility in Rancho Los Amigos, and it looked at Enemies use versus Bisacodyl. And 42% of Bisacodyl users experienced at least one episode of incontinence when using the suppository, whereas the number dropped to only 3% for those using Enemies mini enemas. And then this is a case study looking at the effects of Bisacodyl on the rectal mucosa.
Hey, Deb, sorry to interrupt. We're not seeing that slide. We're not seeing that slide.
Ryan, do you have the slide that has enemies versus bicicotal?
Yeah, I had a network failure here and I tried to turn. Let me stop and then bring this back up again. I'm sorry. All of a sudden, this thing just stopped on me.
We're
Technology.
full of technical difficulties today, Vicki. Apologies on.
No, it's our first one, so of course there had to be trouble.
Even when we did the little troubleshooting session, you never know what might happen. I could try to pull my slideshow back up, but I'm worried then that maybe, let's see.
I rebooted it. I'm just
You rebooted?
getting
Okay,
to that slide right now, and then I'm going to share it.
perfect.
Sorry,
Thank you,
I
Ryan.
don't. Some network error popped up, and I didn't know where you were until I started hearing again. All right, hold on. Get over here. There we go.
Vicki, you tell us when you see a slide that says enemies versus bicicotal.
There it is. Perfect. Thank you.
Perfect. Wonderful. So just to kind of reiterate, since the slide wasn't there, looking at this study at Lasso Ranch Amigos, 42% of bicicotal users experienced at least one episode of incontinence while using the suppository, whereas only 3% experienced that when using Enemies Mini Enemas. And then on the right of the slide, you'll see a couple little pictures. This is just a study done by Saunders looking at the effects of bicicotal on the normal rectal mucosa. So, for up to 30 hours after bicicotal use, inflammation persisted, as evidenced by neutrophils present in that superficial epithelium. So there was inflammation in this bottom picture that lasted for up to 30 hours. These changes actually mimic a mild acute colitis. And then there was also, for these patients, there was mucosal discharge that persisted for up to 3 days after discontinuing the use of bicicotal. So I would just like to point out, kind of the differences between what's happening when you're using bicicotal. It's almost causing like a chemical reaction that can cause issues with incontinence as well as that discharge, and not really reported at all with the use of Enemies. So next, I don't know, Vicki, I know you're familiar with Enemies, but the rest of you joining us today, Enemies is a mini enema. It's about 1 teaspoon of liquid, very simple to use. And Ryan, because you're using this on a regular basis, do you want to just go through and share actually, the usage steps?
Yep. So what I use is Enemies Plus. It's exactly the same size. The only difference is the plus means 20 milligrams of benzocaine. Every other morning, I have a skilled nurse that comes to my residence. First thing she does is she does a DIG check to make sure there's no hard stool. Reason for that is with any agent, you need it to hit the rectal wall and not have a blockage there. So if there is hard stool, which most of the time there's not, she'll remove with a finger's length. When she determines that there's a clear passage, then she'll proceed to twist off the tip. She'll then lubricate the shaft and then we'll insert up to the neck because this is not a suppository. Once she has it inserted, she'll squeeze and continue to squeeze until she feels that all the 5 ml has been released. She doesn't want to release because she releases, then it can become a vacuum effect. So when she feels that all ml is out, removes right around 2 to 3 minutes, I'll hear my bedside bag fill up with urine, which is an indication to me that it's working effectively. And right about that 20-25 minute mark, I will then produce results. She's been working with me for quite a few years, so she understands my routine. She'll then go do a ditch check to make sure there's no loose stool. Most times there's not. If there is, then she'll do a ditch stimulation for about 30 seconds to get that loose stool to come down. I'm done with my bowel program in less than 30 minutes. I'm in my chair anywhere between 10, 13, 14 hours a day, depending on the day. No drippage, no leakage, no accidents. I don't wear any diapers. I don't feel like I'm going to leave my home and be humiliated. I don't even think about bowel program once I'm done with my bowel program because I know that it's improved my quality of life, allowing me to go out and do the things I'm doing, like being an attendee with this presentation today.
Thank you, Ryan. Vicki, I switched to the next slide. Ryan, I'm on the slide that says the mechanism of action slide.
You're good.
Okay, perfect. I just want to make sure we're all at the same place. So, as Ryan mentioned, he is using the Enemies Plus, which is this red box here, and it has the added 20 milligrams of benzocaine. Enemies, regular Enemies is 283 milligrams of docusate sodium, and then the Enemies Plus is the same, the 283 milligrams of docusate sodium with the added 20 milligrams of benzocaine, which is, for patient or persons like Ryan that, have an injury at the T6 or above, could have AD. It's a great option, as well as, patients that are dealing or persons that are dealing with painful, bowels if they have hemorrhoids or fissures. Again, the benzocaine, helps in that area as well. And as Ryan mentioned, in most situations, there's an evacuation time of 1 to 20 minutes after the enema is used. And so, there's not a lifestyle revolving around that bowel program or waiting for something to happen at an unpredictable time. And I guess at this point, I'd like to just, if there's anyone that has questions, Ryan is great. If you have any specific questions for Ryan about his journey or his experience, he's always willing to, provide as much information as possible. If you have any questions for me or Vicki, if there's anything that we didn't touch on that, maybe inadvertently in our technical issues got skipped over, please bring that up. Vicki, are you there?
I'm here. I apologize.
Okay.
Maybe I have myself muted. I turned everybody's mic on. You're still muted, so you'll have to unmute if you have a question. But yeah, if you have any, now would be a great time. I know at some point in all of our journeys, we've struggled with this issue. Todd, I see your hand up. Go ahead. Just hit your unmute and go ahead and ask your question.
Veterans of America. Brian, I appreciate you coming down. We're in Minnesota, you're someplace warm, so and your willingness to share what your journey has been. And I've been in the chair for 40 years and I've had a similar beginning. This goes back to the 80s when Ducalox, and I was calling it Biscadel, so I learned something today. So at any rate, I just wanted to say that I handle on a regular program, and with the help of a different product, but everything, I could go up to 4 or 5 hours of trying to evaluate that I wasn't going to have an accident. So going from less than an hour has been a complete game changer. Thank you again.
No, absolutely. And I don't know if it's me or the network system in general. You're breaking up a little bit. Were you saying that you are actually using Enemies now, or are you just now learning that this is a game changer?
In the last 10 years, it's been a game changer to the type of bowel care that I do now. I used to use 3 suppositories, and that was unreliable. So for years, I suffered through many things like that. But now with the new bowel care program, I'm able to be confident on not having accidents and not having to go 4 or 5 hours to take care of my bowel care program.
Gotcha. Okay.
Oh, great. Thank you for sharing, Todd.
Any other
anyone
questions?
Yeah.
Hi, I had a question. My name is Ron. I'm with the Minnesota PVA. Thank you guys all for doing this.
Absolutely.
My question was, I was getting enemies and they were working really well. They switched to a product. It looks very similar, and I'm not sure if I'm pronouncing right, if it's Docusate or Ducosate. It's in a very similar tube, but I don't know that they offer it in the plus. I am a C6, C7 complete, and I really struggle with getting regular bowel programs. I am impacted almost all the time. I've been only in my injury for 4 years. So do you know how we can get the plus size or the plus version?
Well, where do you get Ron, where do you get your product from currently? Are you getting it, through like the VA? Are you?
Yes, yes, through the
Yes.
VA in Minneapolis.
So the DocuSay, our mini enema, with the benzocaine that Ryan uses, is on the VA formulary. I'm not sure if they're just not aware of it. I have communications with the VA. I could make sure, that they have the product ordering information. It could be just as simple as the fact that they're using one product ordering number, which is for the regular without the benzocaine, and they're not, not inputting the other product, because they are two separate ordering numbers, but it is on the VA supply for the
Okay.
benzocaine plus. So I could look into that. Ryan, do you know anything else on that?
But I think you hit the nail on the head. So Ron, it is the same exact product to me and Deborah, but when it comes to, it's like you going into like CVS, for example, and you wanted Tylenol, but then you want Tylenol extra strength. They have a separate NDC number, is what Deborah is referring to. So it's likely that they are not ordering with the Enemies Plus NDC number.
Okay, thank you very much for that information. I'll ask my provider, and I'm sure I'll be able to get it. Thank you. I didn't even know it was available. So I appreciate, again, you both being here.
And there shouldn't be any confusion from any pharmacist or anyone out there, because the benzocaine is the only one agent is Enemies Plus. So there's not a suppository with the benzocaine. There's not a large volume fleets or any other agents that have the benzocaine. Now someone can add that, but when it comes into one product itself, sustained as the Enemies Plus is the only one that has the benzocaine.
All right.
Yeah.
Thank you so much.
And there is no difference in cost either between the two products. So, that shouldn't be a factor. And Ron, certainly if you have any issues through your provider, if there's any questions that come up, I'd be happy to provide any information that's needed, or, connect with Vicky to provide information, whatever's needed, so that, you could get access to that benzocaine product.
All right. Thank you, Deborah. Thank you, Ryan. You guys have
thank
been a
you.
wealth of information today.
Very
Well,
welcome.
thank you for joining us.
Yeah, anybody else have any questions or comments for Deb or Ryan? I don't see any. Oh, John, you got your hand up. Go ahead.
So I'm sitting in bed right now after battling the exact problem of constipation this week. And I'm just wondering if, because I've been just like clockwork, I have a daily bowel movement. Sometimes it's big, sometimes it's small, but I'm usually able to have at least something. And now I'm down to using milk of magnesia multiple times this week now, and I'm just wondering if everybody has their routine and all of a sudden it just stops working for them. And normally it was just almost scary fast how fast the Ebonies would work with me. I mean, I'm in a Sure Hands device, so it's kind of like by the time I can get 5 feet in the Sure Hands, to my commode chair, it's a challenge. But then all of a sudden it just stopped working, period. And I'm just wondering if anybody else here has had that happen and what they do to kind of rectify. I'm thinking that one of my downfalls is leafy green vegetables. Any comments would be much appreciated.
Ryan, I see you're on it. I see your hand up.
Yep.
Yes. So John, great question. And this is a tendency, as a joke is here in Florida right now, we're cold, 72 degrees, which is a joke to where you guys are at. And why I bring this up is that we have a lot of our quads and paras because of our nature of not doing so well with this weather compared to you guys. With the lower digits, is they tend to not drink enough fluids, and not drinking enough fluids for any bowel product will certainly cause you constipation. But as you also mentioned, doing the vegetables, and I would suggest doing some type of fresh fruits in the morning. And that's what I do. Every morning I have some form of fresh fruits. I have vegetables, some form of vegetable, mostly salad, greens in the evening, but I'm constantly making sure that I'm hydrated. And hydration is especially key to constipation. Question for you that I have is, I know the sure hands, which you're referring to. Are you using the agent from bed, then sure hands to commode, or are you on commode and then using bowel agent to start your bowel program?
No, actually, I've gotten to a point where if I did stim that morning, I'll have my aide do the did stim, then I'll go get up in the sure hands, and then I'll actually go over the toilet, and then have her inject it. And then by the time I get into my bathroom, which is a 10-foot roll, I'm already going. But it's just really weird that all of a sudden, I kind of think it's because my Sunday is my day of not having a bowel movement, just because of the timing usually. If that is what's causing the problems in my life, is I'm just looking for any answers now, I guess, Ron.
That may do it. We've had issues where some quads would only go 3-4 days doing a bowel program, or they would be in their Hoyer lift and do the bowel program, which doesn't help because they're being squeezed. And then the other factor of it is that they're impacting themselves if they go a day or two more than they normally do. Which is, when I do my every other bowel day, it works. But if I know I'm going to eat a lot on Thanksgiving, I do my bowel program, and the following morning, which is Friday or Black Friday, I'll do my bowel program again because I know I overexerted myself and eating the good stuff.
Okay, well, that's all I have. Thank you, both of you.
Thank you, John.
Thank you.
Well, I want to thank everyone for joining us today. I apologize for some of the technical difficulties we had, and hopefully, you were able to get the majority of the information without too many glitches. I really want to thank Ryan for joining us today. He's invaluable in these presentations and this education, and I'm so thankful he's willing to share his journey. If anybody has any other questions, if not, we will say goodbye. And certainly Vicki has my contact information and Ryan's. We are here for you if you need anything, any resources, any information whatsoever. I am happy to help.
Yeah, and Deborah and Ryan, thank you from MNPVA very much. This was excellent, very informative, and like I said, we'll put it up on our website so lots of other people can get benefit from all the great information you gave. So thank you very much to both of you, and we will see you soon.
Yes, thank
Awesome.
you, Vicki.
You
We
as well.
can certainly work on things in the future as well if there's other areas of interest that your local chapter has. We'd be happy to help.
Excellent. Thank you both. And thank you all for coming.
Thank you very much.
We really
Everyone have a
appreciate it.
wonderful day.